Good afternoon, everyone. Thank you for joining us again for this installment of the Native Strong weekly town hall on the COVID-19 pandemic and its effect and the response within the Native community, specifically the Bemidji area, Milwaukee, Wisconsin. And with us today, of course, is our featured speaker, Dr. Lyle Ignace, who has now been here with us doing this for 32 weeks, 33 weeks, Dr. Ignace?
This will be 32.
32, yeah, it's been too long, I'll say. Just seems like this is just continues to go on and on and on. News of vaccines keeps popping up every day, so we've got some good news here. But with that, for those of you who have been here on a weekly basis, you know we welcome questions. We love having questions from you and from the community. So if you're watching via Zoom, please just drop a question in as a comment in the chat box, and we will get to those as we move along here. If you are tuning in via Facebook Live, just drop in as a comment there as well, and we'll moderate those as we move along. Hopefully our good friend Mark joins us through the presentation here today, but we're going to get started, and thank you again for joining us. With that, introduce Dr. Lyle Ignace. Thanks again, Dr. Ignace, for doing this.
Absolutely. Thanks, Jeremiah, and thanks for coming back for week 32 with updates and numbers in our Native community. You know, some encouraging signs, at least in Wisconsin, that I've noticed. And so welcome back from a long, restful vacation, and hopefully people had a lot of food to eat. So the big topic right now is obviously the vaccines, and the companies BioNTech and Pfizer and Moderna. AstraZeneca is going to be popping up pretty soon, and they're going to be submitting for their authorization fairly shortly. So just a lot of headline news around vaccines, and we're starting to get, at least I'm starting to see more and more information of how this is all going to play out for the U.S. as a whole, but also in its distribution to Indian communities. So I've updated this, and as of right now, the CDC is going to be moving on the phase one, their original approach, this framework of phase 1A, phase 1B. Phase 1A being healthcare providers. So this involves all health services, whether you be a doctor, nurse, MA, dental, behavioral health, anybody who has interactions in a face-to-face encounter, rendering services. And so it's a pretty broad definition, but that would include pretty much every essential worker at our facility. We all have direct contact with individuals, so that's the healthcare workers. The second part of this phase one is the extremely high risk individuals, and these are obviously individuals with severe diseases, okay? But we're also more specifically talking about individuals in long-term care facilities and nursing homes. Now, I put a few numbers up here to kind of give you an idea of what kind of framework we're talking about. So we know right now there's approximately 20 million healthcare professionals out there. This is including, you know, our first responders and such that help support hospitals and clinics. So about 20 million. The other interesting part of this, and I've been trying to go through this through the data that I'm getting, the rationale as to why nursing home and long-term care facility is also part of this phase one approach. Now, we know long-term care facilities, nursing homes, these very high-risk population makes up about 1% of the U.S. population. So we're talking about 3 million individuals in the United States. Now, what's interesting about this age group, and we're talking primarily people 70s and 80s, 70 and 80-year-olds and older, what we're finding out is that this particular group makes up about 40% of fatalities. So all of the fatalities that you are hearing right now are comprised primarily of long-term care and nursing home individuals. Now, this doesn't include the individuals that are outside or who are at home but have severe disease, but this is a pretty high risk group, and so they also comprise of hospitalizations, whether that be on the regular general floor of a hospital or in the ICU, and but a big portion of the fatalities in the United States is related to this population. So you can see why the priority to address this high risk group, because as I'll explain at the end, towards the end, when I give an update on the data, you can understand why this group is targeted and will be targeted as a high risk priority group as part of this first round of vaccinations. Now, the second phase of this would be individuals who live at home. Yes, they have chronic care conditions, multiple risk factors, and they comprise of about 87 million people. So you can see where that initial approach in phase one, second phase grouping, you get a bigger swath of the population. And then in phase three, essentially goes to the general population as a whole. So as we go through the discussion of vaccines and how much can we get, how much vaccine can we get in the short term, and Pfizer feels it could get about 40 million doses for distribution within 4 weeks after it gets approved for its authorization. So now we know that, this in a perfect world, we're talking if 100% of all healthcare workers and all nursing home long-term care facilities get this vaccine, that we could hit a big group of individuals right off the bat. But we know it's not going to be 100%, but we will be able to cover everyone in this phase one within the first 4 weeks, based on what Pfizer can get to us here in the United States, 40 million doses within the first 4 weeks. So that is actually good news. So just some perspective in why groupings and numbers are placed to these phases. And so for those individuals that are eligible to receive the vaccine, what is being reported out, sorry, let me get some coffee. Give me a second here. Sorry about that. So when the people that are eligible to receive the vaccine, the safety profile on it is actually pretty good. And most of what I'm hearing about side effects from the vaccine are primarily what most people would get if they were to get the flu shot. If they get the flu shot every year, that's pretty much the same type of symptoms that people would get. So Just like with the flu shot, you get local irritation, maybe some discomfort. You may get some mild body aches, maybe a low-grade temp. Some folks have reported out some headaches with this, but for the most part, the symptoms, the side effects are pretty minimal. And so that's the immediate, the long-term effects of the vaccine. Pfizer and Moderna are reporting out no serious adverse events. So no data on any side effects at 30 days and at 60 days. So this is actually pretty good news on the safety front. We know the efficacy of both Moderna and Pfizer are roughly about 95%. So these are really, really, these are really strong vaccines that we have, and their effectiveness are actually quite striking, really strong, and their side effects are minimal at most. So I pressed the button, and I don't think I lost anything. I think I added 2 blank slides. So, so as I mentioned, so that phase 1 group, the phase 2 group, these are the high-risk individuals, and this is the 65 and older age group. And these are individuals with chronic conditions, chronic lung disease, heart disease, people with severe obesity, uncontrolled diabetes, kidney problems, liver problems, cancer, cancer treatment, transplants, immunocompromised individuals, people who have autoimmune deficiencies, and or poorly controlled HIV or AIDS, and individuals who are on long-term corticosteroids or other immune weakening medications. So I think if I was to mention a few examples of what that would be. So let's say someone has rheumatoid arthritis, someone who has rheumatoid arthritis, chronic joint conditions, and they are taking medications like steroids or something like Humira as a disease-modifying drug for the rheumatoid arthritis. That would be an example of someone who has taken medications to weaken their immune systems to improve their underlying conditions. So that would be an example. Perhaps even someone like lupus and treatment for lupus, people who have systemic lupus erythematosus, that would be another example of an autoimmune by immune weakening medications. So last week I had mentioned that there was new data that was coming out that the CDC was going to adopt some new recommendations, specifically around individuals around quarantine. Now, what's important about this is that they're shortening the time course from 14 days to 7 days. And I'll just go through an example of what this is. So let's say you were notified that you were exposed to someone who became positive. Now, your risk to exposure is because of the individual, doesn't necessarily mean that you have COVID. Now, the way to help expedite this, rather than saying, okay, you got exposed, you got to be isolated for 2 weeks, they're shortening that by looking at how and why the studies that are coming out that actually support reducing 14 to 7. So in order to do this, I know when we get high-risk exposures, we tell folks to go home and that you're isolated for 2 weeks. We know this doesn't work well, particularly individuals who have to work. And so it's pretty hard for individuals to stay out of work for 2 whole weeks. Now, how this works is individuals who are exposed, okay, doesn't necessarily mean they have the have the virus, But if they get tested on day 0, so the day they get notified of the exposure, they get tested, that will come back more than likely negative. Now I'm talking about all negative cases here, negative exposures, negative test exposures. Positive tests are different. So on day 1, day 0, you get tested. You still need to quarantine and mask and keep the isolation as you are for the first 6 days. On day 7, you do need to get tested again. Now, if that test comes back negative, your quarantine ends, and you can go back to your normal routine of work, or however, whatever your situation needs to, be in the public. You would be able to safely go out there and say that you more than likely don't have it. Now, the rationale for this is that if you're going to be positive from a high-risk exposure, there's a 95% chance that if you were to get it, that you would have shown signs or symptoms by day 7. The flip of that would be that there's only a 5% chance after day 7 that you would actually have COVID. Now, they're reducing that quarantine from 14 to even 10 days, mainly because there is only a 1% chance after 10 days from that exposure for you to actually get COVID. So this is actually a pretty reasonable approach to addressing and minimizing people having to quarantine for so long. Now, obviously, high-risk exposure, you go get tested, the test comes back positive, that puts you in a different category. But we're talking about the high-risk exposure. You're getting tested, it comes back negative. CDC is now recommending that you need to get a test in 7 days from that exposure. If that comes back negative, your quarantine ends and you can go about your activity. So CDC is now making this as part of their recommendations, which I think is actually a pretty good idea, getting people back into working, especially individuals who are hourly employees. This will have a huge ramification for them to get back into their jobs and getting back into an ability to generate income. So now, a couple headlines I'm sure most people have heard about. So Moderna has now submitted for emergency use authorization with the FDA for their drugs, and I just found out this morning that has occurred. And so they have a sit down, I believe, with the FDA to make a decision on the 17th, December 17th. Pfizer has their decision date, I believe it's going to be December 10th. So these biotech companies are lining up now, and they're going to come forward now and start to look to the U.S. and the FDA to authorize their use, which to this point I think is actually a good problem to have. So now, what people may have heard right now is that Pfizer, it's actually BioNTech is the name. BioNTech is a tech company out of Germany. Pfizer partnered with BioNTech, but now the UK, what everyone is probably thinking, how strange it is that the UK has already authorized its approval overseas. Pfizer is going to give them 800,000 doses, and they're going to start immunization, their inoculation campaign on Monday. Now, if you didn't know the process by which these vaccines and how these biotech companies are giving out information, you probably wonder, why is the UK getting first dibs on this versus the United States? Well, the reason here is that in Europe, in the UK, BioNTech/Pfizer, their rollout of information was very different than here in the United States. overseas, they had arrangements with the United Kingdom to have blocks of information and data given to them in chunks. Whereas here in the United States, all of the information is given all at once to the FDA. UK has had this rolling pool of data coming back to them on a regular basis. And so they've been, I guess you could think of it as one step ahead of the FDA and how they're getting the information and how they're reviewing it. UK has been reviewing it as they've gone forward. And here in the United States, FDA is just getting one lump drop of all this information. So you could make the case that the UK was at least thinking more advanced in how they would get the information rather than at the end get one big drop of information. They've been getting a rolling amount. So they've been reviewing this all the way along. So for them to actually go ahead and approve this vaccine ahead of the United States, they've been able to do that because they've been getting the information in more real time than we have here in the United States. Now, really, the difference is only going to be about a week. The anticipation here is the approvals of the vaccine, the Pfizer vaccine, would not be any different than what the FDA does here in the United States. The approval processes are very similar. They both have their independent advisory groups that review the information and make their final recommendations on the vaccine. So that's going to be no different. It's just the timing of and how UK was able to process everything versus the FDA. They did it smarter. And as a result, they've been able to reach a decision faster than we have. Now, I think the flip side of this would be, now that we know that the UK has actually approved of the vaccine, I would be pretty hard pressed to say, the FDA wouldn't do it. I would be absolutely amazed if the FDA did not approve of Pfizer's vaccine. So, and that decision should be coming December 10th, which means the immediate distribution of this nationwide would occur within the first 24 hours. And so that's going to be pretty dramatic turnaround, and being able to get immediate vaccines with immediate inoculation campaigns everywhere, which would be a tremendous feat to do in short order. Now, interesting, I've heard individuals, providers come on shows and talk about in papers that have been written is at what level of vaccination does the US population need to get to induce a herd immunity? Now, right now, if we look at what would take, at what population level would herd immunity be induced where we render the virus ineffective in communities to infect individuals? So right now, people are saying about 70% of people either having it or being vaccinated to get to that threshold. Now, given the current population of infections and the assumed asymptomatics rolled into that, we would need the rest of the population, at least 60% of the population, to actually get the vaccine. What that would translate into would be 200 million people in the United States. 200 million of the 335 million would need to get the vaccine. So that would be 400 million doses, okay, to us to get to that level where we'd render this virus to be ineffective in transmitting, and that it would burn out in communities. Now, 200 million people, that's a lot. It's a lot, 400 million doses, basically meaning that each individual would get two doses, an initial dose and a booster. So 200 million people. Now, all the advisory and experts on sitting in these Operation Warp Speed, the military feels that it could distribute that many. The limiting factor here is, are there going to be enough biotech companies to be able to create that many doses, not just here in the United States, because there's agreements throughout the world, and we're talking about over 7 billion people worldwide. Can these biotech companies create enough vaccine to be able to meet the demand and to get to these herd immunity levels that everyone is starting to talk about? That's where you need more than just one company to be able to do it. Moderna would certainly help fill those shoes. AstraZeneca, when they go for their approval, would be able to help fill in. And so we have this whole cohort of companies being able to produce and then distribute these vaccines on a much larger scale. And that would be some feat if it was able to do it, and do it by spring of April of 2021. I'm not saying it can't be done. It can. It's just the process by which all of these steps have to be fulfilled and authorizations. And we're just starting to get into those authorization schedules. And so these companies have already been producing huge millions of doses already. So again, once they get the approval, they can start unloading, and then they're going to have to start backfilling orders. So at least millions, I would think at least maybe 100, maybe 200 million doses could be produced for the world within the first 4 to 6 weeks, and then the race will be on to manufacture and keep up with the demand. And so that's going to be interesting to see how this all plays out, especially after we get past phase 1, because there's that huge population, not just here but worldwide, that have chronic care conditions that will obviously meet the need and the criteria to be vaccinated. So the other thing that has come out is that Pfizer and Moderna are not recommending vaccines for pediatrics right now. There's not enough data, and the trials are ongoing right now to help support children. So there's no information out there to support its efficacy as well as its safety profile. So right now, pediatrics, it is not recommended for pediatrics. It has not been given authorization to do so. So we're talking about adult vaccinations right now. And just a reminder, with these vaccines, so individuals who've already contracted coronavirus, have recovered and are doing fine, they're not eligible to get the vaccine. The general sense is you've already got it, so you don't need any protection because you already have the immunity to it. So you can already think of all of the, if you want to think about, all of the individuals that have had the virus to date. We're talking about over 13, almost 14 million people. Well, that's 14 million people that do not need the vaccine. So that's where we're at right now with the headlines of the vaccine and all the information. And so to keep you up to date as to what's going on, what we'll do is we'll get right into the numbers. And so worldwide, 64 million people have contracted the virus, almost 1.5 million fatalities. Here in the United States, 13.6 million cases. And believe it or not, we've conducted 194 million tests. Now that's not per individual. I'm just saying we've conducted that many tests, which that many tests certainly is more than most countries' total population as a whole. So I'm sure we all know of individuals who have gotten tested. I've gotten tested. And so could very well be maybe close to half the U.S. population has gotten tested already. In terms of fatalities, almost 270,000. Here in Wisconsin, 331,837 cases. The number of recovered, 254,365, and the number of fatalities, I do believe this is higher than this. I think it is over 3,000 fatalities here in Wisconsin. So as we go, the Indian Health Service, there are 573 federally recognized tribes throughout the country. There are federal, tribal, and urban Indian health centers throughout the country. 5.2 million estimated Native Americans in the country, and nearly half Native of the Native population utilize the Indian health system. So it's a good place to start when we look at the numbers. So looking at the Indian Health Service numbers as of November 30th, we have from left to right, we have the accumulated rolling numbers of tests being done with the accumulating numbers of positive tests, and this is by area. So there's 12 areas within the Indian Health Service. When we look at the date of November 30th, we see that some different profiles are starting to shape up. So the highlighted yellow areas are the areas that I feel are the most active and at least trending wise on an upward trajectory. So we have Bemidji, Great Plains, Navajo, Phoenix, and Tucson. That's this week. Now, just a point of mentioning here, we see that Navajo area is over 1,500 cases. This is really high, and I know I used to work in Navajo for 10 years, and so I know the landscape. I know the area very well, and this is the most cases that Navajo has seen at any given time. So we know back in June and July, during some of the summer months, that their numbers were quite high and having some of the highest incidence rates in the country. And they went down, and they actually had some very good numbers in the early fall. However, that has changed, just like the rest of Native country has changed as well. And they are really marching up very quickly from week to week, which is concerning because it almost makes you think, when is that peak going to occur? When is that a peak? When that peak occurs for Navajo, we've seen Oklahoma City. They may have reached their peak, and maybe they're on the downside of their cases. Phoenix appears to be on their upswing, and so trending wise, as we see through Indian country, that not all areas are the same. Some are trending downwards, some are upwards. I just know in the month of October, things were really bad across the board. Now, I would say half the areas in Indian country are still bad, and the other half are starting to turn the corner and start going downwards. So looking at the Indian health system, looking at the system outside and how we count numbers is just as important within the Indian health system as it is outside. I've taken the liberty to go through all of several states that represent some of these IHS areas. And what I specifically want to address is, what is the impact outside of the Indian health system? So the Wisconsin the Midwest area, the Great Plains, and the Billings area, I get the state's numbers, the state demographics of native counts. And so when we start looking at Bemidji, Great Plains, and the Billings area, when we add those up, it comes up to 23,734. When we look at the difference between within the Indian Health Service and what's occurring outside, there is an additional 9,600 cases outside of the Indian Health System. So combined, we have 33,346 estimated cases within these, just in these areas. So that's a 40% increase outside of what IHS is reporting. So if we translate that across the board of all Indian country, we know people live on reservation, we know people that live off. So within IHS, there's a total of 106,393. Adding 40% to this, we're now looking at an additional 43,000, or almost 149,000 native cases throughout the entire country. Now, this is an estimation. I'm just broadly giving some broad estimates as to what, but I wouldn't be surprised if the numbers actually may be higher. I think they may be higher. I think living in the northern parts of the country are much different than natives living in the southern part. And so the rate of infections may actually be much higher off the reservation that we can't account for. So that's certainly possible. But whatever IHS is reporting out, roughly estimate at least 40% more cases. These are confirmed more cases outside, which would be about 43,000 additional cases outside of the IHS. So it's important to keep in mind, that the native population are not monolithic in how we utilize health systems, because we can utilize both the IHS and the public sector. So it's just important to realize that the numbers are going to be much greater than what the Indian Health Service is reporting out. So as we start looking at the Midwest, the upper Midwest as a whole, we see that Wisconsin is starting to slow down, and the numbers are starting to dramatically decrease. We have states like Michigan and Minnesota, roughly about the same. Indiana appears to be maybe on a downward trend. Illinois was really surging for about 3 weeks and almost hitting 100,000 cases in 1 week at one point. They seem to be slowing down as well. Now, what may be a little, what people need to take into account is that we are coming out of a holiday weekend. So it may be still too early for the effect or the impact of the holiday weekend on the numbers. So we're going to I'll keep an eye on this, and I'll certainly give you guys more feedback next week when we start looking at the numbers of what the holiday weekend will have in our areas. So looking at our states, more specifically, Michigan and their respective tribes, because of the long weekend, it was somewhat of an abbreviated data collection. So I wasn't able to give you all these numbers last week, but if you go to the bottom where it says total native population, Michigan has dramatically increased its number of cases in the past 2 weeks. And so in Michigan, 1,804 cases. Over the last 2 weeks, 617 new cases. So roughly, maybe 300 new cases per week over the last 2 weeks. Now, when you look at how many native cases in Michigan comparative to the state population as a whole, just over 3% of the native population in the state of Michigan now has been confirmed to have COVID. Looking at the state of Minnesota. So there was a 1 week pause in reporting the numbers by county, so I'll catch up next week. But again, if you go down to the bottom, we see that Minnesota has now 2,782 cases. That's over almost 1,100 new cases in the past 2 weeks. Roughly a little over 500 per week. So they have dramatically changed. This may sound kind of familiar because I was pretty heavily emphasizing the activity of cases in Wisconsin. Things are starting to change. Wisconsin was a hotspot for weeks and weeks before the other states. Now that Wisconsin has hit a peak, we're starting to see different numbers, but now we're starting to see Michigan and Minnesota's numbers starting to go up. And so Wisconsin was ahead of these other states, is the bottom line. And it looks like as Wisconsin is going down, the others are going up, and natives are no different in getting rolled up into this surge as well. So now the number of cases to the native state population is now at 3.1%. So Michigan, 3.1%, Minnesota, 3.7%. When we get to Wisconsin, we start looking at Wisconsin numbers, again, a pause in reporting out the numbers by county. But we now see that there is 5,102 cases in Wisconsin. In the last 2 weeks, 1,321, just about 600. So that's about what I would expect given its trajectory over the last several weeks, but I suspect the numbers are starting to plateau. As the numbers start plateauing, Wisconsin is plateauing and is actually decreasing. I suspect that the number in the native communities will also start to decrease as well. Now, translating this into the number of cases to the state population, Wisconsin's native population is nearly 10%, comparative to Michigan, Minnesota. That's a fairly significant difference when you're looking at these three states more closely. So a lot of activity, a lot high incidence rates that are occurring in Wisconsin is mainly in this Fox Valley. This is starting to ease, but the Fox Valley area is particularly impacted, and we're talking about tribes such as Stockbridge, Menominee, Oneida, Saucon, and Forest County as being the most impacted tribes in the state of Wisconsin, mainly due to these high incidence rates that are occurring in the Fox Valley. So it's important to know, and people and tribal members of these in the Fox Valley area will need to really hunker down moving forward. Now, this is a little interesting as you look at this. So this, if you look at it kind of like as a weather map, you see on the left-hand side the incidence rates of cases per 100,000. Now, last week, November 25th, looking at this profile of the state, you see the high incidence rates primarily in the upper Midwest and all throughout the plains and the Billings area. Now, as the week has gone by, we're starting to see this kind of receding effect occurring. Montana is starting to go down. We're seeing the Iowa going down. We're seeing Wisconsin going down. And it looks like it's just kind of shrinking the incidence rates in these areas, and these are highly populated native areas, are starting to shrink. And so it's interesting to see these maps slowly over time, as you can see what areas are really high, what's and what's surprising and what's not. I suspect as time goes by, and even by next week, we may see this map shift again. And it would be nice to see that the other Midwest and Plains states not be this dark blue anymore. So looking at the right-hand side. So if we see November 10th, we're looking at the number of cases in the last 7 days. A slight shift. The top 3, top 4, California, Texas, Illinois, Ohio, that really hasn't changed. Florida is there, Michigan is there, Pennsylvania, Minnesota has gone down. But look where Wisconsin is now. On the 25th, there was 44,000 cases in the past 7 days. This is reported out by the CDC. Now, when you look as December 2nd, you start seeing Wisconsin sliding in these numbers. And by the CDC numbers, we're looking at 29,924. So it's a pretty big drop from 1 week to the other. And that's really great news. And could this actually be the downward slide for Wisconsin that we all been hoping and waiting for? And by these numbers, it certainly would be a good indication that that is exactly what is happening right now. So as I mentioned, this is Wisconsin's racial demographics, 5,102 cases. Overall, there have been total 50 fatalities in the state of Wisconsin for natives. This week, there's been 4 new cases. The week prior, it was 12 cases. So could this be this indication that the cases are starting to slow? And it's quite possible that we are seeing the native cases starting to slide down, just like the state as a whole is starting to show. Another indicator in the trending of cases by age demographics. Now, the rates of infection by age essentially haven't changed a whole lot, but when you start looking at time frames, dates and time, we see that, even as far back as September, the age population that had the most cases was always the 20-year-olds. And every week, it has always been the 20-year-olds. They always lead in the number of cases. Now, when we start looking at November, we see that the numbers kept rising and rising. Starting about November 18th, November 19th, November 20th, those numbers, I started to see that the numbers were starting to peak. And right before Thanksgiving, my sense was that the numbers, my sense was looking at the demographics, the age demographics, is that they're going to start sliding. And we're going to not just peak, we're not peaking anymore, that we're actually going to start descending in numbers. And that's exactly what has been occurring. So when we look at December 2nd and the age group numbers, we see just a huge difference from even a week ago. Again, the 20-year-olds are leading the number of cases with 4,300 cases, but every age group across the board is starting to drop. So it's not just one particular age group, it is all age groups are starting to drop. And compared to the week prior, even from November 18th, this is huge, huge drops. So much so that we hadn't seen these kind of numbers since mid-October, early part of October to mid-October. These are the kind of numbers that we were dealing with back then. So now, again, I mentioned we're coming out of a holiday. And so it's quite possible. And I still feel that we are on a downward trajectory. The numbers are flattening out, and when we start looking at trending, this is the rolling 7-day average of cases here in Wisconsin. So I mentioned, back November 18th, 16th, 18th, up to the 20th, the numbers looked like they were peaking. They were high record numbers, but they were peaking. We weren't getting the steady, huge chunks. There was breaks in these trends, so you couldn't rely on every other day as being, is this the number that's going to break us and we're going to go higher? There were these breaks in numbers. It wasn't for lack of testing, because we were testing a lot. But not every day was consistent with what a normal trend in a negative way should be. So we peaked about, looks like November 17th. We had that record one day of almost 8,000 cases. Since then, we've been on a trajectory down. So this is going into the Thanksgiving weekend. We're going down. We're a full week out of Thanksgiving Day, not the whole weekend, but at least from Thanksgiving to today has been a week. We are still on that trajectory going down. I had told my staff this morning that if I felt like if the state's cases came in about 4,500, that this would be, at least in my opinion, an indication that we're still following that trajectory down. Because normally, every week by Thursday, we would see, I had mentioned that, there's a 3 to 5 day window where from exposure to infection with symptoms starts to occur. So 3 to 5 days, we are now 1 week out of Thanksgiving. If Thanksgiving was going to be this nidus of infection, that we would have started seeing a huge trajectory, a huge bump in the numbers of cases. And that's just not what we're seeing right now. That's a good sign. Now, this is Wisconsin. I'm just talking Wisconsin. I'm not talking throughout the United States. I'm just talking about what the trends have been here in Wisconsin, what I've observed. We should have seen, if Thanksgiving was to be such a huge spread of infection, we should have seen huge numbers on Tuesday, Wednesday. Today, we should have seen even more numbers if this was the case. 4,500 is not the case. Now, I think once we get through the weekend here and starting next week, we'll be past that 7-day window of that chance of infection. If we can get past this weekend with numbers that are still around 4,500, I think we will have dodged another surge here. So, but we'll see. We'll see. The numbers look good right now, but we'll see how we do coming out of the weekend. For people that live in Milwaukee, these are our numbers out of Milwaukee County. Almost 6,500 cases in the past 14 days. 236 people have been admitted to the hospital with 90 fatalities. When we look at the age demographic, the breakout, we see again, just like Wisconsin and every other state, that 20-year-old age group has the highest number of infections. As we go to looking at who gets hospitalized here in Milwaukee County, we see some cases, young people less than 20, 30, even in their 40s, but those hospitalizations really don't start occurring until 50 and older. And then once we get into 60, we see very high numbers in the 40s, high 40s and 50s. That's pretty significant, and probably looking at maybe 120, almost 50% of all admissions in the past 14 days are 60 and older. So that's a pretty significant indicator as to who gets admitted to the hospital. When we start looking at the fatalities and the breakouts of age groups there, again, we've seen no fatalities of 29 and younger. We've seen 1 in 30, 1 in 40, 3 in 50, and then 60, we see this huge double-digit bump, and then obviously 70 and older. So the vast majority of fatalities that are occurring in the 60 and older age group. And we start looking at, of the age groups of 60, 70, 80 year old and older make up the vast majority, almost 50% of all fatalities are occurring in the 80 plus year olds. So I wanted you to, so this is just highlighting why, and this goes back to the Operation Warp Speed, the CDC, and its recommendations of who gets the vaccine and which age groups get the vaccine and what will be the biggest impact. So this slide, I know I've spoken to this slide many a times, but it really is to highlight what, obviously how the number of cases have been ongoing to date. If we look at the lower half of this, we start looking at the hospitalization rate, the ICU rate, the case fatality rate. But within that, we need to get context as to what we're seeing. And so in the past week, we've had over 25,000 cases. We see the number of admissions to the hospital, the number to the ICU, and the number of fatalities. So I just mentioned in Milwaukee County, high case rate in the younger age group, 20-year-olds, and that's certainly what we're seeing statewide. But the hospitalizations start occurring in the 50, and the fatality rates really start accelerating once we get into the 60, 70, and 80-year-old group. And more than 58, almost 60% of all fatalities are occurring in the 80-year-olds. So when we talk about age group and risk, we're talking about probably a good population that are in a nursing home or in some type of long-term care facility. So you get a better understanding, or at least a rationale as the approach as to why phase 1B high-risk group, like our elders, like our chronic care conditions, like our individuals that reside in nursing homes and long-term care facilities, what a vaccine would actually do. This is important to know because if we start looking at healthcare workers vaccine, okay, that high risk group, now they don't make up a lot of cases, the number of COVID cases, but they make up a huge portion of hospitalization. They make up a vast majority of fatalities. So an introduction of a vaccine into a population of this group, of this age group, would have such a huge impact, not only on the reduction of infections, but now we're talking about an introduction to a vaccine with the idea that this is going to prevent. You can start seeing the impact of reducing hospitalizations, reducing ICU, and reducing fatalities dramatically. And so that's why this is going to be so important to target this age group first, because it will have the greatest impact of prevention and hospitalization reduction. Now, we talk about hospitalizations, we're talking about cost, bed availability, ICU availability. So we start getting into these more intermediate goals of change here to help support the rest of the population. So preventing infections, 70, 80-year-old group, you can just look at across the board how dramatic this would be in not only reducing beds, admissions, and fatalities, but making more beds available for any more infections that do come in. So huge, huge, huge. I can't emphasize this enough, how impactful the vaccine would be. Now, this is just looking at the overall of the states. But once we start talking about our native population and our elders, and we know our elders have chronic conditions. They reside in nursing homes and long-term care facility. So it's going to be important that our elders, for us to have this dramatic impact in reducing down the infections, but also the transmission, the hospitalization, and ultimately the fatalities, our elder population would benefit tremendously for getting vaccinated. So, so I try to, circle back as, I talk about the vaccines, the safety profiles, the effectiveness, why the rationale for targeting certain age groups, who's at risk, and essentially when this is coming out. So today is the 3rd. Next Thursday will be the hearing with the FDA. My assumption is that they are going to approve this for emergency use, and we'll start seeing the whole country start mobilizing around this vaccine, and we could start seeing people get vaccine in arm by December 11th, and the race will be on. And again, I can't emphasize this enough. I plan on getting the vaccine. As a healthcare provider, I still see patients. I'm still in a high-risk exposure as a provider. But it's important, I feel it's important that not only for myself, I have elders, I have uncles and aunts. Obviously my risk of exposure or even transmission would be high, but I can greatly impact the virus and its community spread by myself getting vaccinated. I build up my immune system. I also help protect my household family and my kids. And, you can see the exponential, effect of prevention with a vaccine. The more the population gets it, the least likely people are going to get the virus, and least likely that it's going to start transmitting, particularly if we hit that herd immunity level. So, good news for Wisconsin. Good news, the trend is down. Good news, the numbers are down. Good news for the nation that the vaccine is coming. I can't imagine that the vaccine wouldn't be approved. So there is good news coming without a doubt, and needing people to be a little more vigilant. I know this is stressful and people are really tired and fatigued from COVID, but an answer is coming, and it's coming in short order. That will help benefit everyone, and maybe even start benefiting all of us by Christmas, believe it or not. And so just everyone play their parts just a little bit longer, and we will definitely see the light at the end of the tunnel and get to the other side of the fence here with certainty. So Jeremiah, I'm going to turn this back over to you for any comments, questions, statements.
Yeah, sounds good. Thank you again. So this kind of goes back to I think the CDC comments on, exposure and then quarantining. And so there was a question, and I'll just kind of start with I'll base it as a story. So a woman and her daughter come in to get tested on Monday, this past Monday. Daughter tests positive, mother tests negative. So now, they're in the car together. Mother sees that as a positive exposure. She did not get tested again since that date. And then she had asked, so, 7 days from Monday, does that quarantine end? Or should she get tested, or should have gotten tested already? Yes, okay.
So yes on both. She should have gotten tested day 0. So just as the daughter got tested, she should have got tested as well.
Oh, she did, yeah. They were both
Okay.
tested at the same time.
Great. So
And at that same time on that test, the daughter tested positive, the mom tested negative.
Yeah. So
then, yes, okay.
the question becomes, when do they come out of quarantine? So now this gets a little splitting hairs a bit. We know from experience that even households, one individual may become positive and the rest don't get it. It just happens. We also have the presumption that if one household member is positive, we assume the entire house is positive, which, right or wrong, you could think of it however you want. But we just know that not every household that has a positive case, everyone gets it. We just know that doesn't occur. But they're looking at minimizing transmission, community spread. And so how do we mitigate, how do we get these folks back into a normal routine, a COVID routine, coming out of this? Now, unfortunately, the daughter, it is now, I do believe they still feel it is recommended that the positive individual does do their 14 days. 10 days, if you're looking at testing them early and getting them negative to come out of quarantine. But the mom, you said the mom got tested, she got 0. Should she get tested again? The answer is yes. Do get tested again at day 7. If that test is negative, the likelihood that she is going to get it dramatically goes down. Whereas after 7 days, if she tests negative, there's only a 5% chance that she will continue to get it. Now, if she wanted to wait 10 days, and if she tests negative without any signs or symptoms, there's only a 1% chance that she could actually flip and turn positive. So, if that makes sense. So, CDC is saying day 1, day 0, and day 7 get tested. If both of those are negative, you could come out of quarantine.
Great, thank you. That's kind of what I thought, but I just wanted to, make that 100% sure from your end. So we're talking about the vaccine and, 90% efficacy rate. So if you get the vaccine, does that, similar to maybe somebody that's asymptomatic, does that allow you to still be a carrier of the virus, or does that kind of pretty much shut it down entirely?
Well, so could you be a carrier of the virus? We know that you'll develop an immune body response. And if it's as effective as they say it is at 95%, that's actually a prevention of 95. So there's a 5% chance that you could still get coronavirus, the COVID, even getting the vaccine. There's still a 5% chance that you still could, but your symptoms would be a lot less if you didn't get the vaccine. And there's been no cases of severe COVID, no severe cases of COVID. And severe, I would render that as being hospitalized, ICU, or fatalities as a result of being vaccinated. So not only can it prevent you from getting infected, but it can also reduce your symptomatology, or even outcome as a result of the vaccine. Now, you asked if could someone still be a carrier? Yes, they could actually be a carrier. And could they be a transmitter of the virus? And so the answer could be yes. They may not be infected, but they could be exposed, get it on them, and they breathe it. They just don't get infected, but they may carry it with them for a while. Now, a while mean maybe a day, half a day, 2 days. So there's still that risk of transmission, even if you've gotten vaccinated. So that's why they're asking people to continue wearing the mask. Even if you do get vaccinated, could that still be a risk of transmission, even though that you won't get it? And the answer is there is a chance that that could definitely occur.
So based at the timeline that we're looking at, the phase 1, phase 1B, phase 2, phase 3, off your best kind of guess, what would, let's say my case, my parents, my kids' grandparents who are 60 to 70, don't really have any underlying conditions, pretty healthy, I would say. When do you think, we could go back to them and say, okay, you guys can expect to get your vaccine X, date? Where do you see that happening?
Yeah, so this phase 1, we'll go through this phase 1 pretty quick. And I'm talking quick, like from day 1, before we start saying, okay, let's start going into phase 2. We could get through phase 1 within about 30 days. We'll have enough vaccine to be able to cover all of phase 1A and 1B. Once we get through those initial rounds, we have doses available for all of phase 1 participants. We can start getting into phase 2. And I think after the new year, probably mid-January, we could start looking at phase 2. By that time, we're talking about close to 2 months of production, and we'll probably have at least a second, maybe a third vaccine company involved in producing. These companies feel that they can get about close to 15 million doses of vaccine a month produced. So we could be looking at hitting phase 2 group, probably mid-January, maybe 1st of February, and look at February, March, April, and getting this 87 million, or we'll just say roughly 90 million individuals in phase 2 to be vaccinated. So what's going to occur up front may seem very chaotic, but that will be the calm before the storm. It is the phase 2 after the new year where the demand is definitely going to go up. We'll have more vaccine, and there's going to be even a more concerted effort of vaccinating people on a larger scale. So I'm looking perhaps in this 60, 70-year-old age group. They're at risk, okay? And so I'm looking at maybe by mid to late January as when phase 2 will start. Phase 2, I would certainly say by February 1st, phase 2 should start. And it'd probably take about 3 months, 3 months of vaccinating to get through phase 2 before we get to phase 3.
Okay, that's good news. So, we just got through the Thanksgiving kind of holiday weekend. I know it's December now, but it's like Christmas is going to be here right before we know it. And, I think I saw a lot of social media stuff and families that, did some interesting things as far as still getting together on Thanksgiving, whether that was having their full meals on a big table outside, even though it was a little chilly, but, they made it work, and it seemed to be safer. People were masked when not eating and drinking. Obviously Christmas is a little colder, at least in, here in Wisconsin. Would you suggest kind of taking even maybe more precautions than people were doing for Thanksgiving, because it seems like the ability to, congregate or hang out outside will be a little less, once Christmas comes along? And if people do obviously start receiving that vaccine, how important, like you said, is it to kind of continue to, keep yourself safe, wear a mask, stuff like that? Just because you have the vaccine, it doesn't necessarily mean you're completely out of the woods.
Yeah.
Correct?
It's kind of an interesting question because if you take it from, it depends kind of a stance. So let's say let's say a young family, let's say a young family, 28-year-olds, 28-year-olds that maybe have 5 or 6-year-old kids at home. That's a pretty young family. Even 30-year-olds with kids. It's a kind of an interesting question because if you look at maybe if it's just young people, 30 and younger with kids, you look at what's the risk. Now, we do know that these age groups do have a higher risk of infection, but as a result, we also know that younger people fare a lot better. They fare a lot better in terms of less hospitalizations, less ICUs, admissions, and even fewer fatalities altogether. We know that no kids under the age of 20 have died from the COVID virus. So if you want to risk stratify which age groups, what family dynamics may be less affected versus, let's say, grandma, grandpa, 60, 70, 80-year-olds, getting together with grandma and grandparents and aunts and uncles, their risk, even though they're not getting as many infections as the younger population, they have much more to lose in terms of hospitalization and poor outcomes. So I think it really will depend on each family's risk, if you want to stratify that risk and really look at if it's just going to be young people, young families together, is that necessarily a bad thing? Probably not. But it's really when you start interacting from younger to older age groups, and that's the risk. And so does grandma and grandpa, aunt and uncles who have problems, maybe they need to wear a mask and really limit their activity or at least their exposure. Not to say that you have to put them, everyone's in the house and grandma's in the garage. No, I'm not talking about that kind of stuff. Or, put grandma in the basement while everyone's on the main floor eating. No, I mean, there may need to be that distancing. There may need to be some masking. And believe it or not, maybe people need to open their windows and get some fresh air moving and circulating a little bit. So, there's ways that you can help kind of minimize it. It won't be zero, but it may allow you to have some sensibility of togetherness during the holidays, and maybe the times with people are smaller. It's not an all-day event. Maybe it's maybe it's a half an hour event. Maybe it's an hour event. Maybe you make grandma some bologna sandwiches and just meet and say, okay, here's your bologna sandwich. You got to go. It's hard to say. I think you can make it. Being creative in finding out what works. I think Thanksgiving, whatever people did in Thanksgiving, if we come out of Thanksgiving really dodging a surge, I think what people did in Thanksgiving could be translated to what they can do for Christmas, and so we'll see. I'm not trying to be facetious or be too funny about it, but I think there's ways you can help mitigate it. And I know this sounds weird, but individuals that are highest at risk in a household when they're maybe a small gathering, maybe they do have to wear a mask. And maybe having a mask becomes creative. I don't know, maybe a mask that looks like Santa Claus, with a beard and stuff. And, I'm just saying, Grandpa might get a kick out of that one. So there's ways you can be creative and keep that distance and wear a mask in under a household for a shorter period of time rather than an all-day event. I think could be doable.
All right. Well, I'll give you one more question and then we'll kind of sign off for the day, and you can as you do every week, just kind of give us your parting words. But Patricia, I had a question. You mentioned in past presentations the possibilities of, virus mutating. I mean, viruses do mutate. Do you think this can affect the efficacy of the vaccine for people, or, is this not really an issue for consideration at this time? And I'll leave it at that and leave you with the final word.
Sure. That's a really good question. And so this vaccine was based off of the virus that came out in the early parts of January, February, and March. That's what the basis, the not only the prototype, but also the manufacturing and the how this vaccine was created was based off of early, springs, what it looked like. Now we know over time all viruses mutate. It's just a matter of to what degree does the virus mutate. Are they big chunks, little bits in here and there? It's hard to say. What will be interesting, now we know these viruses don't like mutate from one division to the next. It takes many divisions and many transmissions of many people before we see from patient 1 to patient 1 million and what that virus looks like. It will be different. Will it be dramatically different where the vaccine doesn't become effective? Time will tell. What I mean by that is time from time patient 1 to patient 10 million or 100 million person vaccinated. I guarantee you that 200, 300, 400 million patients who got vaccinated to the virus that would look like what was 16 months ago, it will be different. Will it be dramatically different? Probably not. And the reason why I say that is most viruses don't mutate to become more lethal. They become less virile. They could still be contagious, but they don't make themselves more lethal. If that was the case, I think, the swine flu epidemic of 1918, if that was the case, I think we probably wouldn't be where we are in terms of population as a country, just in sheer population numbers. That would have been even more devastating than it actually was. So historically, viruses do not make themselves to be more lethal. They could change and could maintain or find ways to protect themselves to allow to be continually contagious, but not necessarily more lethal. So whatever vaccine is created now will address this time frame of what the virus and impact it does on the population now. If we're still dealing with this beyond summer into next year, we may be looking at having to create another vaccine for what the virus looks like in 12 months from now. So it really will depend. I think the hopes here is that the vaccination campaign will be so effective that it will render this virus ineffective and burn itself out, and that we won't see it. And then we'd have to worry about the next SARS-CoV-3 virus, whenever that may be. Whether that's 18 months from now or 18 years from now or never again, we'll have to wait and address it when that happens, when it occurs. So I hope that answers your question, Patricia. But the effectiveness of this virus of this vaccine on this virus right now should render it pretty effective, I would think, for the next 12 months, without a doubt. So I talked a lot today about the vaccine, the approvals that are coming, the phases by which who's going to get the vaccine first, side effects, risk factors, numbers in Indian country, the trends that are going on. 32 weeks. I've been talking about all of this, trying to keep people aware and familiar with the terms and the concepts. These are science and everyday living don't exactly always coincide together. And so people have gotten a real crash course in science and public health 101, and they've gotten a lot of it. And so I hope in these conversations that we have that understanding maybe the science and maybe the public health approach around what's occurring, I hope this audience gets a better understanding after hearing this discussion as to why decisions are made and how they come about. And 32 weeks is a long time. We're almost approaching a full year of this. It's remarkable that not only do we have one, but we have two vaccines that are on the docket to be approved, with probably three more biotech companies for approval. Not just the United States and Indian country and the world as a whole are going to see vaccines in short order. I'm actually pretty optimistic with what's occurred and how quickly it has developed. Like I said, the medical, the modern medical mobility of what has occurred has never happened anywhere in the world at any point of our existence. And to be able to create this within essentially 6-7 months, where we could very well have the ability to shut down a pandemic probably faster and more effective and safer than any point in our history of the world is just absolutely amazing. A lot of things have happened between last Christmas and now, but I think people should feel optimistic. They should feel that a solution is not only on the horizon, but it's going to be coming to your front door. And that's going to give people a lot of peace in mind and hope and safety and prevention. And the next 4 weeks are going to be huge, what occurs here in Indian country. And so the best, and my hope would be that everyone, when that time comes, or when you get that call to say, hey, you're eligible to get the vaccine, do you want the vaccine, that you would jump at the opportunity and get the vaccine when it does become available for you. As I said, I will, as a healthcare provider, I'll be one of those first ones, and I have no problems getting that vaccine, and I hope to be at least the first one in our agency to be able to get it. And so there is reason to feel optimistic. I do believe that, and I think this audience should also feel that as well, because help is definitely coming. So until next time, we'll be updating more information, and hopefully next Thursday I will actually have a decision, and we can talk about more about what's going to happen after that final approval decision is made. And so everyone maintain, stay vigilant, and stay strong. Till next week, take care, stay safe.